Great. Hi, everyone. I'm Jim Kovach, former NFL player and physician, and been a long time associated with the football players study at Harvard. I'm honored to serve as the moderator of this very timely panel on strengthening cardiovascular resilience. And I'd like to introduce our panelists, and after this introduction, we'll get to a panel discussion. We'll go for 45 minutes, and then we'll have 15 minutes for questions to the audience. And so just want to lay out the objectives of the panel are to identify ways that heart health impacts the brain health and really kind of talk more specifically about this connection that Harvard has uncovered and is publishing on now between brain health and heart health. And then we'd like to bring some of the attention to the cardiovascular conditions that are disproportionately suffered by former NFL players, and also to discuss some of the emerging interventions and technologies that are really revolutionizing cardiology right now, really kind of changing the game to reactive cardiological approaches to preventative ones, where you can identify things like plaque burden and low attenuation plaque earlier, and then you could actually treat it prior to cardiovascular disease. So it's a management tool for life. The goal is to share the latest research and then provide actionable strategies for former players and their families. Just wanted to mention here that what I'm going to do is just introduce and give a one-sentence bio to each panelist, and then I'll start by offering one question to each of them, and then we'll get into additional questions that we can answer on a panel basis. But Dr. Talisa Spikes is on our panel here. She's a professor in the Emory University School of Nursing, and her research interest is in chronic stressors and their impact on cardiovascular disease. Dr. Herman Taylor is a professor and director of the Cardiovascular Research Institute at the Morehouse School of Medicine. He's also a member of the National Academy, and he's an adjunct and longtime adjunct professor at Harvard and Emory as well. And then John Farquhar is a president and chief executive officer of HeartFlow, Inc. John is a former NFL tight end, and he gained 20 years of experience after retiring from the NFL in the cardiovascular space. Prior to HeartFlow, he was the VP of and general manager of Medtronic's aortic business. So you can talk a little bit more about yourself when I give you this question. I'm going to kick it off with Herman. Can you provide, Herman, some background and overview of the football players' health study at Harvard? It's kind of, I'll call it a movement in a sense into this discovery of the cardiovascular connection to brain health and brain and repetitive trauma and chronic inflammation. And as it pertains to hypertension, cardiovascular disease, and also to aging as well.
Jim, thank you very much. And again, good morning, everyone. This has been an incredibly exciting seminar, let's call it, up till this point. And I want to congratulate the first panel for having a very important, vital discussion about pain. And before that, both Rachel Grashow, as well as our fearless leader, Dr. Savante, talked about the interrelatedness of all of the things that characterize a life in football. And one important thing that I think we began to explore fairly early is that the body systems are not built to be contained in silos. Things happen across systems. One system may support another in a certain way. Another system, if there's a derangement in that system, some malfunction, can actually aggravate problems in another. And Alicia pointed out, Dr. Whittington pointed out, that one of our early studies suggested that ACL tears, for instance, were attended by greater incidence of heart attacks. And we can talk about the possible mechanisms of that. But that was one of the things that really made the strong point that it's not just about head injuries in isolation. It's not just about orthopedic issues in isolation, but there's interrelatedness and connection across systems. Specifically, and I'll let the rest of the panel respond as well, specifically, it's important for us to recognize, again, what Dr. Grashow pointed out, that if you look at the end of the line, that most players succumb, die of cardiovascular issues. That's irrefutable. It is important. It's something that clearly we needed to attend to as a study. And I think we've moved in the direction of recognizing the prominence of cardiovascular disease as a problem, and also focusing on how we might approach attenuating, lowering the risk that players face. And we can get into more details as we go along. But that's an important tenet of the Football Players' Health Study.
And feel free, Talisa, to comment, and John, are there examples of these stressors that exist in a former NFL player's life? Could you comment on kind of the environmental aspect and its contribution to cardiovascular disease?
Yes. So again, briefly, my name is Dr. Talisa Spikes, and I'm an assistant professor at Emory in the School of Nursing. So my research focuses on that very thing, chronic stress and its contribution and influence on vascular aging and hypertension risk in early midlife African-American women. And so even though my population is different, it's very synergistic to these NFL players. And I think of that as akin to this quote when we talk about the maternal mortality rate in Black women. How are these women showing up in pregnancy before they conceive? So it's kind of the same analogy with these football players. How are they showing up in this NFL setting? The obstacles and challenges that it took to get there, the wear and tear on the body, not only physically, but psychologically, the different stressors, financial stress, chronic stress, and Dr. Grashow mentioned that earlier about learning more about the social determinants and how these things are becoming embodied or contributing to weathering per se, and its risk to heart disease. So we're still disentangling that effect, but what Dr. Taylor said was very strong in that these body systems are very interrelated. So it's not just the hypertension, what's going on, but if we have these heart issues, guaranteed, it's also happening, some manifestation and changes are happening in the brain that we don't see. So it's very multi-layered and it's not linear.
And John, maybe if you could comment a little bit on when cardiovascular disease begins to manifest itself, perhaps not to the open eye, but just physiologically within the body. I mean, there's been fascinating research that, if you could talk a little bit more about that, generally points in the direction of cardiovascular disease starting earlier in life.
Yeah, sure. Happy to comment, but full disclosure, I'm not a physician, so I'll defer to my much smarter folks to my left here. Just quickly, by way of background, so I'm retired NFL player. I played for 5 years, and I really appreciated the comment somebody made earlier. You know, the NFL retired me. I didn't retire from it. A lot of choice in that one. But I've been very fortunate since then. I played mostly for the Steelers and the Saints, but Coach Ditka wrote my recommendation to business school. I went to Northwestern Business School, and then went into medical technology. And then most recently, about 5 years ago, was very fortunate to become CEO of a company called HeartFlow. And what we do is we use artificial intelligence to measure coronary artery disease much more precisely than can be done with the existing technology, and certainly more precisely than than the human eye can do. And what we know, and this isn't necessarily a heartful finding, and but it's well understood in the medical community, the heart attack that happens today, that disease developed 15 years ago, 20 years ago. And what we know with the NFL community, the retired NFL community, heart disease in and of itself is the world's largest killer. Number one killer, more than all other cancers combined. 1 in 4 Americans die of heart disease. So that's a big problem in and of itself. In retired NFL players, it's even worse, 1 in 3, okay? And so this is sort of the universe is very, interesting way of sort of intersecting my own personal journey with, my professional journey. I've been through the Brain and Body program. I thought of myself as in shape and what have you. And just by fortune, luck, really, I found myself at the company that I lead now. I had a heart flow test. I found out I had not an insignificant amount of coronary artery disease. And that was disease that was not picked up through, the screening that was made available to me through the NFL. And that was a wake-up call, and I feel very fortunate. Managing heart disease or preventing heart attacks, it's just your classic, you can't manage what you don't measure. And if you don't know it's there, you can't manage it. And we're very fortunate now to have technology that can do this. And one of the goals that we have is getting the word out with retired players. We have a free test which is available to any retired player, irrespective of whether or not you got tenure or anything else. If you put on an NFL jersey at any point in your life, you've got eligibility to come get a heart flow test. And hopefully we can, if we find the disease now, there's great therapeutics and great other avenues that can prevent the heart attack that's going to happen 15 years later. But just to get to kind of your question, Jim, heart disease starts with the formation of plaque. When plaque is young, it's soft. Okay. Over time, as it heals, hopefully it heals. It becomes calcified, and a lot of times you'll hear people talk about having a calcium score or whatever. It's that soft plaque that can rupture and can have a heart attack, and it's that soft plaque that you don't know it's there, okay? So you gotta know it's there. Once you know it's there, then you can manage your other risk factors and hopefully prevent your heart attack.
Herman, can you talk a little bit about the points just made, and then when we talk about the phrase chronic inflammation, I mean, it seems like that's being identified as one of the potential contributors to this. What does that really mean, as a term of science and art, and what can individuals do about it? And trace its elements, if you could, to these other aspects of health, like mental health, and then also the physical trauma that we accumulate during our careers.
Okay, big question, Jim. But let me see if I can parse that a little bit. I guess I didn't do much of an introduction, but my professional history is that I started out as an interventional cardiologist, spending all day in the cath lab, making angiograms and, when necessary, engaging in what we call, back when I started, angioplasty. So I spent a lot of time dealing with and thinking about coronary disease. Over time, I became more interested in prevention and led something called the Jackson Heart Study, which is the largest study that NIH has ever funded, and looking specifically at issues around heart disease and health in African Americans down in Jackson, Mississippi. Some of the issues that surround the specific type of heart disease that John was talking about, that is coronary heart disease. That disease that leads to the largest category of problems inside of heart disease. That disease that leads to heart attacks. That is, it was very precisely described. It starts at an age that you wouldn't suspect looking at autopsies of teenagers who die in car accidents, for instance, historical studies, already found the beginnings of coronary disease in a lot of those kids. The American way of life, the American way of eating, the stressors that we encounter, whatever your ethnicity, and sometimes aggravated in certain ethnicities or marginalized populations, all those things come together with some of the things that you can rattle off, cholesterol, blood pressure, et cetera, to begin coronary disease. And it can creep up on you silently. There are some things to pay attention to understand whether or not you're at risk. I don't want everyone just walking out in fear, but in increased awareness, a state of increased awareness. I think you guys know a lot of this. The American Heart Association talks about the essential 8 aspects of how you live your life that are important, and also 4 of those are important numbers. The 4 important numbers, blood sugar, blood cholesterol, blood pressure, and I'm going to come back to that because I think it's really important to emphasize. People have long called it the silent killer, and that's an appropriate name. And BMI, and we're doing some new work on weight and former players that we can talk about that sort of nuances the idea of BMI and accounting for the heavy muscularity that a lot of players carry even after they stop playing. But those things plus sleep, exercise, and I'll call it nicotine exposure, which is meant to include both smoking and vaping, because both are no good, right? And diet, and we can get into particulars of that. If you are out of line with some of these things, and we can talk about what out of line means, then you are at increased risk for coronary disease. If your family history indicates that people die early, die suddenly, you are at increased risk. The importance of the type of work that John and Jim are involved in terms of detecting silent disease is that we used to say a lot, and the other cardiologists in the room will remember, we talked about how often with coronary disease, your first symptom can be your last, meaning it can result in sudden death if undetected. So this work is very important, but I will wrap up my little segment here by saying there are other forms of heart disease that can be equally deadly. How many of you have heard of heart failure? Okay, heart failure is distinct but overlaps with coronary disease. And undetected, untreated high blood pressure can lead to heart failure. And if today you are diagnosed with heart failure, your prognosis in terms of longevity, on average, is about like being diagnosed with colon cancer. In other words, it is not to be taken lightly. The risk factors are very similar to the ones I just listed. But hypertension, I think, is such an important part of that picture, and we must do more to make people aware about the risk and also become aware of what their own personal numbers are. I'll stop.
Well, thank you. Thank you, Herman. That was very good. And it kind of sets up my next question for Talisa. Is like Herman was talking at what I'll call kind of a broad-based population level. There's some fascinating data around specific subpopulations, women, for example, black populations, and disproportionate risk. Can you talk about your research and into those areas and what you found?
Yes. So the foundation of my work was similar to Dr. Taylor, his clinical experience. So in my clinical practice, when I practice as a nurse, I began to see an influx of young African American women being admitted with heart failure, largely due to uncontrolled hypertension. And these women were between the ages of 29 and 31, 33, very young. And I thought that was it was enlightening to see so many young women being admitted with heart failure, but which was rooted in a pre-existing diagnosis of hypertension, which we know is very easily manageable and modifiable. So that set the stage for my work. But as I've continued to progress, it was some data that came out through Cardia, which was a big epidemiological study that looked at young adults. And this was published back in 2018. And what they found was that when we speak about the subpopulations, 30% of African Americans, by the time they reached 30 and 35, so this was African American men and women, 30% of that cohort had already been diagnosed with hypertension. When compared to their white peers of the same age, they did not get or develop hypertension until they were roughly about 45, 55 years old. So you can see the big age gap. Hypertension onset was definitely much later and at older ages for the white populations compared to Black. So that also leads to, with these NFL players, it's no different. Even though they are an anomaly, because you would think that they are typically healthy given the sport that they're doing, but why is the heart disease prevalence so high? So again, it goes back to how are they showing up in this sport, but then the other things and the stressors that they're accumulating in the process, in this trajectory. And one thing I wanted to add to the question that you asked Dr. Taylor about the chronic inflammation, Dr. Taylor mentioned about the essential 8, and addressing those categories can help attenuate or reduce the risk of inflammation, which is considered to be a common denominator for many chronic diseases, including heart disease. But it's so important that you are aware of those numbers, because that's something that you all have the power, we have the power to change. And it was a JAMA study that just got highlighted this morning on Good Morning America, where they talked about just this very topic. The awareness of hypertension is at an all-time low. So it's, definitely a call to action, and specifically for the younger and early midlife adults.
Thank you. I want to switch gears a little bit and ask for each of you to respond to the next question that has to do with what we're seeing on the medication front. One can't hardly open the newspaper and not see something about one of the GLP-1 agonists or new therapy, primarily for obesity. But I'm just curious, and I know many former players have contacted me about, determining or examining whether there's relevance to the relatedness of cardiovascular risk with these therapies, and what your thoughts are on. So, Herman, why don't you kick it off again, and then we'll go to Lisa and then John.
Okay, all right. I'm assuming you're referencing the GLP-1 agonist.
PCSK9, Repatha is another well-known one.
Okay, very good, very good. Repatha, an injectable drug that lowers cholesterol dramatically, has an interesting story, and I think it sort of interweaves with the notion of resilience in a way, and I know that's on part of our discussion lineup here, if time permits.
Yes.
I will say that, but to keep it simple and straightforward, it was found first in a family in France that if you had a certain genetic profile that involved a certain gene, the PCSK9 gene, that you would be at excess risk for heart disease, coronary disease specifically, if you had that gene. Then they found, very interestingly, in the United States, in a population of African Americans, that the deletion of that gene, right, would lead to an extraordinarily low level of LDL, that bad cholesterol. And if you had that particular genetic profile, that you had extraordinarily low incidence and prevalence of coronary disease. And it speaks to, on the one hand, the importance of having diverse populations that you study, inclusive populations, so that we get a full view of the genetic variety of human beings, because that can lead very directly to new cures. So the old pattern of focusing research in the majority population only has some serious flaws. And this is one example of how, again, having all people involved and represented in these studies is really critically important. Well, now that we can give an injection to help offset the effects of that particular protein, we can dramatically drop cholesterol and save lives. So Repatha is a great drug, and I'm very proud of sort of the history of how it got confirmed and got out there for people to use. The GLP-1 agonists are a class that people are, I guess they're thinking about putting it in the water because it's so popular, both for weight loss, but of course for the management of hyperglycemia and other things that have been, other benefits that have been derived or proven true. Very dramatic, consistent evidence in people who have diabetes for the prevention of coronary disease and other major cardiac events, right? So particularly, that is particularly strong in people who have a history of heart disease previously for prevention of subsequent events and prevention of heart disease events in people who have diabetes. In terms of using it as a primary prevention, I think the evidence is accumulating there, but it's most strong in people who have established disease, people who have diabetes. And there may be some additions to that.
Yeah.
But, yeah.
Lisa, do you have things to add to that, or?
No, just to dovetail from what Dr. Taylor said, it has shown very great promise in individuals with high cardiometabolic risk profiles. So we think about metabolic syndrome, in decreasing future cardiovascular events. It's kind of getting overshadowed by the side effects, but that seems to be the minority, and it doesn't seem to overpower the benefits still from the GLP-1 agonist. Yep. And cost.
And cost, yeah.
Yeah, I'll just add a couple things, and this is, again, I'm feeling less and less intellectual the more I listen to everybody chat up here, but this is for the former players and the family. For me, like keeping it super simple, you cannot manage what you don't measure, full stop. And as an athlete, which I don't know why I still consider myself one, even though I'm not. I probably from the time I was 12 to the time I retired, every day I was measuring something. It was how much I was lifting, how much I weighed, how many calories I was eating, you name it. And you got to apply that to your heart health. You just got to do it. And I think if you know that, then what's occurring with some of these medications, they're wonder drugs. We know for a fact if you're on Repatha, for instance, a PCSK9 inhibitor, that bad soft plaque that nobody wants, that stuff that potentially can rupture and cause a heart attack, over time will go away. Okay, but again, you're not going to be able to get a PCSK9 if you can't substantiate that you've got soft plaque. And the reason I know all this is because I am on one, and the only reason I'm on one is because I had my test. And by the way, I'm on one and it's paid for. so I'm not, it's insured. So for me, it's just down to, you gotta measure something in order to manage it. Nobody should die of a heart attack. It is preventable. Unfortunately, it hits retired NFL players harder. There's still a lot to learn, but we don't need to wait till we know everything in order to start preventing it now. And so that's, if you're a loved one, and I know we've got some siblings, my sister's here, so we got a good brother-sister crew in the audience today. Please get the word out, because I think we can make a difference now in helping guys and prevent some of these bad outcomes.
So the idea would potentially be to start a screen or inquiry much earlier than traditionally, like in maybe when players are retiring, maybe 35, 40, when people, I remember vaguely being that age, and you're still not thinking about cardiovascular health at all, but that's maybe the time to do that. And it seems like the pendulum's swinging to more personalized approaches as opposed to the correlative that we have currently.
Yeah, and the only thing I'll add to that, and somebody said it, I think that what they said was be the hero of your own journey. I mean, know your numbers, right? Know your blood pressure, know your LDL, know your risk. I kind of think like, in a weird sort of way, the medical community, you can walk through it and sort of have a lot of problems and keep walking through it. So if you're not your own advocate for yourself, then it's a lot easier for you to kind of fall through the cracks. So I think that's great advice, whoever mentioned that.
Yeah, I think, let me echo, you have to be an advocate for yourself. But you also have a community, a family, people who care about you, who can take part in that advocacy as well. And I know there are wives and partners of players who are very involved. I remember, and Ross can relate to this, working with veterans back in the day. We had, as caretakers, we always noted that when the wife was in the room, as we were interviewing the veteran for whatever heart problem it was, you got a lot more information, you got a lot more reliable information. You ask the question, so how many drinks a week? And the guy will say 2 beers while the wife is doing this in the background, and she gives the real deal. You can play a vital role in the health of your loved ones, and also by pushing and promoting prevention. And John just mentioned knowing your numbers. That's really incredible, and really incredibly important advice. But also the act of support, that call it a cocoon of support around the player. The players often have sacrificed tremendously for their families. Now, after the game is done for them, it is really important for the family to be equally energetic around supporting that player and his health. And I just want to be sure that we all get that message. Last thing I'll say, one of the studies we did on resilience, and we focused this in the African American community, but I think there's an important lesson for all. And that is that in communities that were characterized by high levels of what we call social cohesion, high levels of activities together, high levels of social support, that the chances of them having ideal cardiovascular health were dramatically increased. So that doesn't sound like hard science to a lot of people. That's not a medication, that's not an intervention, that's not a procedure. But the environment that you create around the person you're concerned about with that level of support, that interaction, I think one of the other speakers talked about, I forget how he put it, but the notion of, he talked about an additional social connection every day. That idea is scientifically and repeatably verified. And I just want to say, and Talisa's an expert on this, I would want to say that that is something that cannot, the value of which cannot be overstated.
And it's free.
Right. Exactly.
That's great. I'm always one to love to look over the horizon, like what's coming next 5 years from now. You know, it's hard to say 10 years, who knows? But what are your feelings? We'll start with you, Talisa, on important research that needs to be done. Like what's the next stepping stone for cardiovascular research in your mind?
I think it's gonna really, and it's so funny that Dr. Taylor mentioned that about the social support. I think it's gonna be imperative to really tap into community, especially when you're dealing with these subpopulations. It's a lot of, I always say, and I refer to even with my study, it's the for us by us study, because the answers largely to how we address this cardiovascular epidemic problem in this young subgroup is going to come from the population. Historically, science has come down that we have the solution, so we're going to push it. In these, many times, these interventions did not work; they have failed, and so now I think it's going to really be driven largely from the people to us, the scientists and clinicians, and we'll help formulate what that looks like. In addition to precision medicine, because some populations will need therapeutics, but I think that's going to be the future wave of where this is going to go.
I agree. One of my mentors said one of the most underestimated sources of insight into disease and its effective management resides in the patient. And the better job we do of listening to patients, their specific complaints, and their concerns, I think if we use that as a guiding light to what our research engages us in, I think we're well advised to do that, and we'll come up with better and better solutions. I'll be perhaps a little overly specific about two things that I think are really important. And specifically, we're involved with the football players' health study. One, the effective control of high blood pressure. It's an old problem, but we have so many ways to do it without the side effects that a lot of people, particularly men, have been concerned about over the years. But having that on the shelf, but not embraced and adopted by patients and their physicians sometimes is a problem. One of the things we do in the football players' health study is a specific intervention that looks at how we can effectively control blood pressure in people whose blood pressure is not controlled. Doing that kind of practical research that has a hard outcome like better control of blood pressure is critical and important for the future. The second thing that's fairly specific to some of the research thrusts that we're looking at in our study is looking at the phenomenon of aging and early aging that Dr. Grashow talked about in her opening remarks. To understand better what things can help expand not just lifespan, but also health span are critical. There's an array of different avenues being explored, from the genomic, epigenetic, and all those omics that you hear about, to other things that are less exotic but still incredibly important. I think focusing on the control of something we know ultimately kills people, but is silent and therefore not attended to, I think that's critical and an important thrust for the future. I think understanding longevity and health span is another important area for the future, and I think there's a lot of promise there.
Yeah, and I'll just build on that. I mean, for my world, which is more focused on coronary artery disease and AI, we really believe one day you'll get a sort of an AI scan for your heart, very analogous to how women get mammograms every year. And we think the technology will get there. It's going to take some large randomized controlled trial data in order to get all of that paid for, but a lot of that is already underway. But we really see kind of the same paradigm shift occurring in coronary artery disease that has previously occurred in kind of cancer detection. So I think that's coming. I think relative to sort of the Harvard players study and retired players, I think there's a lot more to learn. There's some reason why NFL players are at disproportionate risk. And so encouraging participation into the study, and then as we previously discussed, knowing the numbers, familial support, et cetera. I think we don't need to wait for the future. We can make a big difference right now.
All right, thanks.